every test. Yeah, it's probably going to be limited to an hour. So we can't be y'all are getting off in the weeds so bad. Oh my God. Y'all are complicating stuff that ain't complicated. I know you're going to say, this hard, that's easy for you to say. You're right. Now it's hot in here today. I froze my butt off last time. Oh, if I would have had a speaker, I totally would have played that outside. Somebody call 911. Miss Sutton, so wrong. I said all y'all would have laughed.
They took a long time to get real fire.
Yeah, that wasn't a drill.
It wasn't a drill.
So they wasted our time.
No, it was not a drill. I never found out what the real was, but I don't know.
Somebody might blew up their microwave.
All right, I want to do this real quick because I didn't understand that some of y'all are lost in last year's Easter egg.
Oh.
Every different kind of shock. What is the definition of shock? All right, so this is how every shock starts. I have inadequate what? Perfusion. So that means my oxygen is going what? Down. And this is globally. That's all the tissues. What's under tissues? Cells. So, I've got inadequate perfusion. There's no oxygen getting there. I don't care what the reason is. So I'm running out of oxygen. What happens when you run out of oxygen? Anaerobic metabolism. So it goes to the tissues. The tissues are dying. Y'all know that. So it resorts to cell hypoxia. What is this? This is that. That led to this. Inadequate perfusion for some reason. If it's obstructed to the forward flow. If it's distributed, everything's being distributed to the wrong place. If it's cardiogenic, what's causing that? Your heart ain't beating right. Every type of shock leads to this. Then this, tissues don't get enough oxygen. Just go on down. The cells don't get enough oxygen. Cellular hypoxia, what happens right here? Anaerobic. That's why the shift. If we had enough oxygen, we wouldn't come right here. Where do we want to catch this? Right here. Hopefully. How can we fix this? How's the first way that we could fix that? Give them a little bit? A lot. Non-rebreather, that little thing quivering at the top on that little O2 thing on the wall. Cell hypoxia, we've shifted to anaerobic. I told you, it's only 2 ATP, right? And what else is a byproduct? Lactic acid. So, this is an insult to the system. What's going to kick in? Fight or flight, right? So your heart rate goes up, your oxygen consumption goes up. It's going to get worse. If you can stop that sympathetic up here by treating the cause, you won't get down here. Does everybody understand what I'm telling you? Guys, y'all have figured out now, I don't want you to memorize crap. If you can think through this, every type of shock you can understand, it's all going to lead to this. It's a different problem, but it's all going to lead to this. 2 ATP. Now I don't have any energy, and it's going to make oxygen consumption go up. My heart rate's gone up. How long can we stay that way? So now I'm breathing 4 times a minute. So what am I not getting? Oxygen. My heart's not beating but 30 times a minute. What's my perfusion? Down. What's my cardiac output? Down. What's my mouth? Hypoperfusion. Do you see how it all feeds back in? If you don't stop this, what did I tell you happens right in here? The sodium-potassium pump fails. This is vital. So, what lab? Lactic acid. What if it's 20? Guys, that guides your resuscitation. If it's 2, we need a little bit. If it's 4, we need a little bit. If it's 20, oh shit. Might be dead. Do we just rely on that? Absolutely not. My sodium potassium pump has failed. All the cells are hypoxic anyway. Sodium's going to go in, potassium is going to go out. So, what follows salt? Water. All these cells are going to, everything that's in there gets thrown out. And it's just like toxic waste at this point. So now, all this that's in here gets thrown out too, and it starts going into other cells. Even more sodium, even more waters. They start lysing faster and faster. What's floating around? What's toxic to your heart? What's your cardiac output? What's your map? Shock. What labs? CMP. Immediately. Lactic acid, CMP, CBC, and an ABG. I want to know what that pH, what I'm starting out at. If you don't have a baseline, you don't know if you got better or worse. You're like, oh, 6.9 is great. Well, not so much. All right. This is continuing. What's happening? Heart rate slowing down. Cardiac output's getting worse. Tissues. So the cells are hypoxic, right? Tissues are hypoxic. What's next? Cells, tissues, organs. What's next? This is where what comes in? Multi-system, organ, dysfunction syndrome. All of this is a cascade. And it happens like this. Sometimes it happens fast, sometimes it happens slow. Tissues, organs, organ system, game over. Guys, once you get here, I have never, this is just my experience, I have never seen a patient come back at that level. I don't care if they were 20, I don't care if they're 18. Especially if they're my age, you better start planning a funeral. And I'm not being ugly, that's just the cold hard facts. 50% mortality rate with this. That ain't good odds. I want better odds than that. I want 25% something. Too many people don't want to practice. Just saying.
Your newest aesthetic designer.
No, that's good talent. You know what?
Yeah, you know, it's not sure. I would be unwell if I was sitting in a room for a long time.
Right? Spray you Lysol.
Yeah, no, I will go and do business.
how we got to that. That's the general pathophysiology. This is the specific disorder that leads you to hypoperfusion. What are the three things? The pump, the pipes, and the volume. This is not just blood. Now, when you understand the pathophysiology, you also understand what? How to treat it. There you go. How do we fix it? In emergency, you find it, what? You fix it. We can't wait. So, which shock is a pump? There ain't no other shock that's the pump. Hold on just a second. So, what causes that? MI? Cardiac output's gonna drop. Perfusion's gonna. What is the definition of shock? Hypoperfusion. Do you see how we just did that? Hypoperfusion leads to what? Cell hypoxia. Leads to anaerobic. Do you see what I'm telling you? This general patho is caused by each one of these. What types of shock affect the pipes? Neurogenic? Yes. This is also called vasoregulatory issues, which was constricted your vasculature. All right. So what about obstructive? So something is affecting the forward flow of what? If my body, now guys, it's not hypovolemic shock. Because it's hypovolemic shock, how you treat it? Fluids, blood. If you got a PE, is that going to do anything? No, you got to treat the cause. Why is a PE affecting my volume, my forward flow? Cardiac output drops, my perfusion goes to crap, hypoperfusion, anaerobic, dead. What's the other one? Tamponade. Now, I've had people say, that's cardiac. Is anything wrong with your heart? It is not. This is extra cardiac. This is not an MI. This is not, well, you might tell me, well, they got stabbed in the heart. That's not the heart. The heart was an innocent bystander. It was sitting there and this happened. And it's not just a pneumo. Tension pneumothorax, because it's doing what? Building pressure on the great vessels and the heart. If you let it swing on over for tracheal deviation, your cardiac output is going to stop. Because then your pump ain't pumping and you don't have any outward flow from your great vessels. It's a double whammy. How do we fix these? PE. You got to give them a clot buster, and every now and then they actually go in for surgery if it's big enough. How about tamponade? Pericardiocentesis. What is the signs and symptoms of cardiac tamponade? Vex. I will tell you. NCLEX loves this. Hypotension. JVD. And what? Sometimes you might see somebody put bradycardia here. What's bradycardia lead to? Hypotension. So, pericardiocentesis, what about the tension pneumo? Chest tube. Guys, the most important thing is not that chest tube. The most important thing is to get that hole to relieve the pressure. We'll make it sexy later, but I got to get that hole to let the pressure out. Did that help? Guys, I love y'all to death. I really do, but y'all are getting so, like, we can sit down and have a conversation and y'all are talking over my head sometimes. I'm like, I never thought about that. My daughter does that shit too. Her IQ is 141 and I know mine's not that. I'll be Googling stuff. Don't make this harder than it is. This is not a hard, guys, I know it's broad. Narrow it down. It's gonna result in hypoperfusion. I don't care what the problem is. If you know that's the patho, and they're having an MI, it's gotta be cardiogenic, and we know how to treat it, because you understand what? The pathophysiology for that, and the cause.
No pun intended.
Why do I lose shit today? It's important. It's always important. But see, that fire drill got me all off. So I told you hypovolemic shock is loss of volume. It's not just blood. It's hemorrhagic and non-hemorrhagic, which one's bleeding and the other one's not. So why this? If you've been puking for 4 days, you're hypovolemic, you're dehydrated. If you've had diarrhea, heaven forbid you've got both. Why are burn patients hypovolemic? So the third space, your skin is burned off. What does your skin do? It holds everything in, and it keeps you warm. Everything is leaking out, especially if you've got a lot of third-degree burns. What is their skin going to look like? What color? Pale. Their skin will be tinting. If they're bleeding out, you're not going to have a chance to get this because it's an acute injury. If they are dehydrated, it's been going on for a day or two, their skin will tint. And that's from vomiting and diarrhea. Hemorrhage is hemorrhage. Where do we hemorrhage? Outside and inside. I swear, if that thing goes out, I'm going to lose my mind. What assessment do we do? Definitely vital signs. Which one am I really looking at? I'm looking at all of them. Blood pressure. Because y'all, if that map's 40, what's my perfusion? Awful. And if I'm all the way down to my heart rate has started dropping, I don't have any sympathetic kick that's going on. Look at their skin. I'm going to look for pulse, motor, sensory. What if I feel right here and I got a pulse, 5 minutes later, I don't have a pulse here, I got a pulse here, and then 5 minutes later I can feel, what's my blood pressure doing? Dropping. I think if this one, if you have a pulse here and nowhere else, is 70 systolic. That ain't good. How do I find out if they have injuries? A, B, C, D, E. If you don't look at, if you didn't chart it, you didn't do it. If you don't look at it, and guys, injuries don't just happen right here. Turn them over. You know what? Your lungs ain't just right here either. You can get a flail segment back here. And when you don't flip the patient and you get to the ER and they find that, you real embarrassed. and it was an open chest wound. How do we treat it? Now, used to, before my students taught me something last semester, we would say, what kind of bed position? Trendelenburg. That is no longer right. And every nurse that's experienced is going to tell you that. We're going to put him in Trendelenburg. No, we're not. It's called passive what? Leg raises. Honestly, all the studies I looked at, both of them don't really help, but one of them really don't help. This is just for you. Well, no, can be important just to show you something. Does anybody know there's just kind of the general bolus that we give people? What do we base it off of? If I got a bad trauma patient, it's 20 milliliters per kilogram, right? Okay, guys, a lot of things go into that. If you got a bad CHF patient that was in a trauma, you still can't flood them with fluid. What kind of IVs? Huh? Large bore. What's considered large bore? 18 and above. What if you can't get an 18? Then you get what you can get. And you don't what? And you don't throw a fit. Right. We'll throw a fit later. Because if you can get a little bit of volume in them, then maybe you can get another IV or have time for the doctor or nurse practitioner to come down and put a central line. If you can get two, get two. We're going to start out with this. And I told you why we don't start out with vasopressors. You ain't got nothing to press on. It's all on the floor. IV crystalloids, what fluids? Lactated ringers, normal saline. That's about it for our world. They use another one in the OR, but evidently it's very expensive. Guys, there's been a shift in the last few years, and we're giving LR a lot more. But what fluid do you only give blood with? Normal saline. You never give it with lactated ringers. And we will talk about that a little bit more in the hematology lecture. So when they tell y'all, hey, go get some blood tubing and get some saline, that's why. Don't pull that LR. Blood products. It's not just packed red cells. You can't just give all that. You might give platelets. You might give plasma. What are IV colloids? Albumin, dextran, hetastarch. The dextran and hetastarch we really don't use a whole lot because they have been shown to cause hellacious anaphylaxis. And anaphylaxis on top of hemorrhage, I mean, we might as well just go kick out the casket. But we do use albumin. Yes, ma'am.
So in hypoflumic shock, is this where you'll use like the
The rapid infusers? Yes. Because if you got a 20, can you use the rapid infuser? You're going to blow it. What she asked was, and if you guys haven't seen this, I'm sure every ER has them of some sort, kind, or fashion. She's asking about the Belmont. I think it can drop 2 liters of fluid in a minute. That's a lot. You need to be monitoring, besides blood pressure, what closely? Breath sounds. Guys, you've got to, if you have a critical trauma patient, how often do you assess them? 5 minutes. And I know you're going to say, that's honey. You're going to be so busy doing all that you ain't got time. If they're halfway stable, what do we move it up to? 10 to 15 minutes. What if they start crashing? 5 minutes, 2.5 minutes, every minute something. Does anybody know what the fluid bolus for septic patients is? The fluid bolus for septic patients is in this formula. What is sepsis? What shock? Where's all your fluid? Out. So are they hypovolemic? Kind of. It's 30. And I know you gonna tell me, Miss Thornton, we gonna drown them. No, you're not. They ain't got no fluid. It's all out here. They look like a Michelin man. 9 liters in under an hour. And that patient was still hypotensive. Now, if it is septic shock, what do we jump to a lot faster that we really don't give in hypovolemic shock? Pressors. Am I really bleeding? No. Am I dehydrated? No. I am hypovolemic, but it's because my volume is everywhere else. So that's not hypovolemic shock. It is a secondary what? Hypovolemia. Because of all this. Anaphylaxis, sepsis, and neurogenic is a vasomotor problem. Everything relaxes and everything goes out and everywhere. What do vasopressors do? Which receptor does it? Alpha 1. Y'all ain't getting away from this. That helps you figure out what pressor. Y'all might as well just put it to memory. Because I'm going to ask you 511,000 times. What test? What am I looking at here? Hemoglobin and crit. I do need to know a CMP. What are we going to draw quick? What if I can't get it quick enough? What kind of blood? Trauma blood. And I want to throw some coags in there. Wait. Control the fluid loss. Stop the bleeding you can see. Surgery for the ones you can't. You can't always see that they're bleeding. They're bleeding internally. Wrong direction. Distributive shock. Excessive vasodilation. So, if I'm vasodilated, where's my fluid? It ain't in the pipes. What's preload? Vastly decreased. This is the amount of blood that I have flowing out. What is cardiac output? Vastly decreased. My blood pressure drops. Sympathetic kicks in. Heart rate goes up. Oxygen content consumption gets even worse. Which leads to what? Hypoperfusion. That cascade starts all over again. We just took a different side road to get there. Right? What is this? This is systemic vascular resistance. Guys, this is this. Your volume, your container has what? Vastly expanded. Vasopressor. That's why they work. Vasoconstriction. I make my container smaller. Everything is vasodilated. Everything leaks out. All the capillaries start leaking. So my container's big and the fluid's leaking out. Now, each different shock under this causes it for a different reason, but it all affects that fluid going out. How does sepsis do it? Bacteria release what? Toxins. These are floating around in the blood. You release histamines, you release cytokines. And guys, our body's trying to save itself, but some of these things cause a bad effect, i.e. capillary membrane permeability, right? And it causes vasodilation, increased capillary permeability. You cannot have septic shock without what? An infection. If you don't have an infection, you don't have septic shock. How do we tell it's septic shock? How do we tell we got an infection? White blood cell count? Fever, maybe. You heard of cold shock, warm shock? It can actually, which one do you think is worse? Cold. That means that, so why do we get a fever? It is, so any bacteria, we all like to exist in our 98.7, right? Every bacteria, every medication, like you'll see on there, don't get what? Don't get it real cold, don't get it real hot, it doesn't work. It's the same thing for bacteria. The body says, ooh, if I can jack this up to 105, it'll kill it. But does that always work? And then the respiratory rate goes up, oxygen consumption goes, and it leads to hypoperfusion, plus all this crap. Guys, I know with sepsis, we got to get them volume. What is the most important thing? This is important. Write this down. What do I have to give them? Nothing else you do is going to work. Draw those blood cultures and give them that broad spectrum antibiotic. A lot of times it's vancomycin or Zosyn immediately. How do you know? How did we figure that out? Through research. And what guides our practice always? Evidence-based. You're going to hear a few terms. Sears, sepsis, septic shock. Does anybody know what the difference here is? What if I tell you all this is compensated? What does that mean to you? I'm trying to save myself. I'm compensating for whatever this insult to the system is, right? How do you know when they are not compensating anymore? Huh? Everything drops. Specifically what? Cardiac output, which leads to what? Hypotension. When that blood pressure drops, you are no longer here. You are now in uncompensated septic shock. So, if I'm in anaphylaxis, what's the defining characteristic there? Your blood pressure drops. And now you're in anaphylactic shock. And then what's the last one? Irreversible. You guys, there's no coming back from that. Yes. And this is where, I'm sorry. I know it's great. You know, I can spell, guys, but when I start writing on the board, I just completely forget how to spell. Does anybody know what Sears is? It's kind of criteria to kind of decide if you're in what? Sepsis. The first thing you have to have is what? Source of infection. And this can be suspected. Have y'all heard yet? Oh, we're going to do the sepsis bundle. Who's in the ER? When you go to whatever ER, ask your clinical instructor to show you the paper. Guys, it's lined out. You have to draw cultures within a certain amount of time. Why do you think they're putting all that? Evidence has shown this is how we save patients. And if you fall out in parameters, you get an ugly email. So, source of infection, tachycardia. You only have to have 2. What else? Temp, tachypnea. I thought there was more. Okay. And it's greater than 12, right? Yeah. Okay. All right. So there's a little bit of problem with this. I can ask Sarah to go run up and down the stairs, and even though she's in good shape, she gonna get 2 of these, right? Well, why is it not sepsis? She doesn't have an infection. So we start thinking at the hospital that it's sepsis if they meet Sears criteria and they have a source of infection. Then you start down that sepsis bundle. All that to say, you have to have a source of infection. Guys, you do not have a question that specifically asks you, what are the Sears criteria? That's not what I want you to know. I want you to know that this is happening. Why is it happening? How are we going to treat it? You've got to remember that about the antibiotics for this type of shock, especially. And if who in here looks at simple nursing? Y'all go back and look at the septic shock. It's right up there at the top. And guys, I ain't trying to. Y'all need to go buy this. No, that's not what I'm doing. But these people talk to people that write what? The NCLEX. They might not always get it right, but it's worthwhile looking. And y'all don't go buy the membership. You look it up on YouTube. Now the membership has got a lot more. Hey, guess what some of my slides are? It's got parts of it in there. Registered nurse RN is another one. And I don't think straight A nursing has, I think it's just a podcast. I mean, I listen to more than that, but I like those. This is just showing you, so sepsis, it is serious and an infection. When you get an infection, do you always get sepsis? No. Thank God. But what is sepsis? It's an inflammatory response on crack. We don't know why it happens. Everybody doesn't develop it. And when I say, because you've got an insult to the system, right? And so it starts sending out all the histamines, it starts sending out all the leukotrienes, and then the endotoxins are floating around. Vasodilation, capillary permeability, but it's still an inflammatory response. Sears an infection, and organ dysfunction is going to start. Septic shock, what's that? Hypotension. They won't add a pressor until they've usually given about 2 liters of fluid. It has to be refractory. Well, guys, we don't want to give them a vasopressor if we don't need it. This ain't go big or go home. And then it goes what? Due to unchecked inflammation. Lactate's going to be elevated. If you caught it early on, it might not be that high. Well, we don't want to get it worse. Their electrolytes will be out of whack. Which ones? Potassium and sodium. Their temp may be up, or it might be kind of low. Their white blood cell count will be either elevated or what? Guys, that's real bad. They're not even mounting a defense anymore. They're warriors, right? They all did. They all laid down on the battlefield. So now I've got like 3,000 instead of 20,000. And they're probably hypo. What's low temperature? Thank you. Lord have mercy. There's too many hypo. Hypothermic. Skin condition. This is just textbook for shock. Pale, it might be pale, but usually it's more mottled. Cool and clammy is, do y'all know what clammy is? Yeah, if y'all ever got real nervous and you feel your palms, and heaven forbid you shake somebody's hand and you're like, that's clammy. They might be diaphoretic at first. They might have a change in level of consciousness. Early on, what is that going to look like? Anxious and restless. I just don't feel good. Then they might start telling you, I feel like I'm going to die. That's from all that sympathetic release. Vital signs. Why did I put this up here? Guys, this is one of the most important indications, one, of perfusion status, And 2, in conjunction with lactate, your CMP, and your vital signs as to how your patient's what? Doing. Are we going in the right direction? Are we going in the wrong direction? Are we just going to get yeeted to Jesus? Oxygen, IV fluid, antibiotics. What about temp management? How do we manage high temps? What's the blanket called? The Arctic sun. The Arctic sun for extraordinarily hot. There's something else we can do. We don't do it a lot. I've only done it once or twice. Huh? What'd you say? It is, but it's internal. You do a lavage through the tube of ice water. Why do we not just throw them in an ice bath? You do. What happens when you get cold? You shiver and you get goosebumps. Why do we do that? Your body's trying to increase your body temp. You are shooting yourself in the foot. Now, if somebody is hypothermic, our trauma doc used to say you get them wet, you get them windy, and you get them naked. I.e., not cold water, because how do we get rid of temperature? Convection, conduction. So if I put something that's halfway cool on top of them, it helps that heat to get off. We do put the Arctic sun on them, but we don't get it so low they start shivering. Or we give them a paralytic that what? Stops that. Guys, what kind of Foley? You might not have ever seen this. Temperature sensing Foley. And I've had nurses tell me that this patient was septic. We don't need that. You're an idiot. Temperature sensing. Guys, you can't get no more core than that. This is even more core than a rectal. Does anybody else know the other one that's very core? It goes down the ET tube. They're disposable. They're not expensive. So is this thing. Guess where else you can put that? Rectal. It's still a thermometer. It's not that big. You just put some lube on it and it's up in the mucous membranes. It doesn't cause damage. Now, if you can put it down the ET tube, put it down the ET tube. And if they look at you like you're stupid, you tell them, hey, I got a temperature read. And it's core. CBC, blood cultures. Why am I drawing a UA on them? I want to know really quick, especially with the older population, is this a UTI? Because that can also lead me into what about their level of consciousness? Guys, even starting at my age, these people, when they get a UTI, act crazy as a barn rat. Like, to the point of being combative. Lactate. So I'm adding something in here. Why on earth am I talking about coagulation?
Because you worried about PIC.
So there is something that is only with sepsis and septic shock. And we've got a slide about it. In just a second. You're going to draw coags in every septic patient. This is important. All of them don't go into disseminated intravascular coagulation. Guys, once you get to that, they're going to bleed out of every orifice that they have. Eyes, mouth, nose, vaginal canal, rectally. Once again, I have never seen a patient go into that. And they'll start what protocol? The massive transfusion protocol. They're going to bleed to death. Guys, we need vasopressors. Which one is number one for sepsis? Norepi. That's just standard of care. Now, if you got a smaller hospital that doesn't have a lot of money, the second one might be dopamine. Guys, dopamine is not a great drug. It's got too many side effects. It causes dysrhythmias, and not in high concentrations. I might need something wet for the heart to beat better. Here's what happens. So, what did I say they're going into? An inflammatory response. You remember with the MI, there was like microvascular injury, and it formed a what? A clot, right? Because this is the same thing. You've got this massive inflammatory response that's going on. Sooner or later, your body's going to say, ooh, I need to make a clot. A lot of them. If I make a lot of clots, what do I use up? All of your clotting factors. Now, y'all listen to me on this. You're clotting. You don't have any more clotting factors. Now, when you start bleeding, what? Nothing stops it. So you are coagulating and bleeding to death at the same time. I know that doesn't make any sense, but if you think about it, you have used all the fibrin. Ain't none left. So when you start bleeding, it doesn't clot. Does everybody understand that? Because this is a very, they're like clotting and bleeding. What happens to all those clots? Where specifically do they get stuck? It's not the lungs.
The micro cross goes everywhere.
Kidneys. Your kidneys start to shut down. Usually they're not first. They might be first if they're going into DIC. If they're bleeding everywhere, we ain't going to get to their kidneys. You just ain't. So we've got excessive clot formation into itty bitty, right? Vasculature. I've used all my clotting factors. So now there's nothing to stop the bleeding. Those little thrombi go to every organ, especially, now they will, some of them lodge in the little vasculature in the lungs, but especially the kidneys, they shut them down. Depleted clotting factors leading to excessive bleeding. Now this is going to blow your mind. This is not on the test, but I want you to understand if you see this being treated. We're going to give them blood products. Does anybody else know what else we're going to give them? Not TPA. You're right there. Heparin. And you're like, they're bleeding to death. They are. But if I don't get rid of the clots, they're going to die anyway. I can treat all that bleeding with what? Blood products. We got a lot of that. If those clots lodge, it's still game over. I don't care how much blood I give them. Does everybody understand this? Guys, this is important. Who's in my clinical group? What did I tell you is one of the most important things to Professor Horton that's in that unit? It ain't the sexy equipment, it was in that closet. The what warmer? The blanket warmer. Y'all can look at me like I'm an idiot if you want to. If you don't get these patients warm, they're going to die. And if you got a septic patient, unless their temp is 105, we ain't going to do this then. You better get that blanket out. It used to be the triad of death, now it's a diamond. What makes it up? Hypothermia, hypocalcemia, acidosis, and yeah. So, this is a diamond. So, they're cold. Guys, if they're in septic shock, they've swapped to anaerobic, right? They're producing what? They're going to get acidotic. If you can just change this, it doesn't have that last part. There's a good chance you might not go into that. Why would you not go get a freaking warm blanket? How easy is that? Now, if they've swapped to anaerobic and they're acidotic, why does that happen? Especially with trauma patients. What do we give bad trauma patients that are bleeding? Blood. What's the preservative in it? Calcium citrate. It leaches the calcium from the system. What happens when you get bad hypocalcemic? Your QRS starts to widen. What's the ultimate wide? Beep. Our protocol for LifeLight, 4 units of blood, we would take calcium gluconate, not calcium chloride. Calcium chloride has 3 times the amount of calcium in it. We don't want hyper either. We put it in a bag of saline and run it in with the blood so that we would stop that. There are ones on here that we can really affect, especially this one and that one. This is not hard. But if you don't do this and do this, this is going to happen, and then this is what? That's DIC. Bad trauma patients will do the same thing. They'll go into DIC. There's one more group. Does anybody know this? Some of y'all might want to go into this. Labor and delivery patients. If they have amniotic emboli or retained products of birth, it'll cause postpartum hemorrhage and then DIC. But it's not every patient. I want you guys to understand the pathophysiology behind DIC. Does everybody have a grasp on that right now? Anaphylactic. So, usually what causes this? Allergic reaction, a lot of times it is to bees, wasps, whatever. What's the number one food?
Peanut butter.
Girl, tree nuts, peanut butter, peanuts. And they sneak peanuts. Guys, I've got celiac. They sneak wheat and so many things I never knew. They sneak peanuts and so many things I never know. And they're like, there ain't no peanuts in it. And you're over there, can't breathe. What sort of shock? It's still distributive. It is a hellacious inflammation to an antigen, right? Here we go again. It's an insult to the system. I've got this bad inflammatory response. My fluid is going to shift out of the vasculature. The capillaries are going to leak. Hypovolemic, hypoperfusion. What kind of metabolism? Anaerobic, cell hypoxia, cell death. There we go. You took a different side road, but I still got to that same thing I wrote down. Pump, pipes, volume. Pipes and what? Volume. Pipes led to the volume. That's not the initial problem. What's the difference between anaphylaxis and allergic reaction anaphylaxis? You have to impact what? 2 body systems. And a lot of times it's what? Respiratory and what else? The skin, the urticaria. I can never pronounce that right. It has to affect 2 different body systems to be considered anaphylaxis. Bronchospasm is a big one. And bronchoconstriction. What do they look like? So initially, are they going to be pale, cool, and clammy? No, their skin is going to be beet red, and they're going to have hives real bad. Why are they short of breath? So we affect upper airway how? Their tongue, it might be like out to here, and like you got that much back there that you're getting air down. You're ventilating through this much space. So there's airway. What's happening in breathing? Bronchoconstriction. What vasopressor? No. Epi, beta 1, beta 2, and alpha 1. One heart, 2 lungs. I need that bronchodilation. Now, what other medicine might, it's not going to be first. You might give them albuterol. What kind of drug is it? A beta 2 agonist. If you are my greatest antagonist, what are you doing? You're fighting against me. An agonist pokes the bear and gets him to run off. It gets me the effect I want, right? Now, when I give them the epi, am I really looking to increase the heart rate? Because you're going to be, Miss Horton, their heart's already going 150. It's not going to have that big effect. I got to get this open or it ain't going to matter what their heart rate is. Short of breath. Edema where? Guys, that's what's life altering. And so what do we do if we got all this swelling up here and I can't ventilate them? You do a surgical cripe. This is swollen shut through. Guys, if this gets swollen and this gets swollen, it is game over. You can't just open their chest and this is swelling shut too. Have y'all ever been around anybody that's really anaphylactic and they're like, oh my God, and they're hoarse. Horse is up here, you might hear stridor. That airway is closing. And guys, your trachea is still your airway. All of it is closing shut. You can't get an ET tube down, you can cut their neck all you want to. It's not going to matter. A hair trigger for an advanced airway. I'm talking about if somebody comes in and they're already wheezing, you hear, get it out. And it's probably going to be a smaller size than we want. But a Dixie straw is a lot better than nothing. After we get all the swelling to go down, we can replace that with a normal ET. If we do what we're supposed to, maybe by the end of the day, we can take them off what? The ventilator. They don't need that. That just secured their airway to stop it from swelling shut. Yes, ma'am.
So, what do you do in that case where like the throat's swelling as well? Is there anything?
Pray? I don't know of anything. I mean, I don't. Yes, ma'am.
Oh, I was just asking what the question was.
She said, once all this swells shut,
Oh, yeah.
what can you do? Huh? Yeah, but the thing is that, guys, everybody reach up and feel. So you ski down the mountain and you've got a little, I don't know what you call it, like a diaphragm. And if y'all have a male sitting next to you, it's a lot easier to feel on them. So everybody feel on the guy's throats. No. There's a little hole. That's where the scalpel goes through. And you put a surgical cripe that we did in the field. You cut, punch through, put a little dilator in it, and put an ET tube down in there and secure it. It's better than nothing. Now in the hospital, it's a lot prettier. But if this is swelling shut, that's right there. I don't know if there is it. Yes, ma'am.
So I've had the pleasure of being anaphylactic a couple of times. The very first time was the worst one though, because I was 3 hours away from any kind of facility. And I knew that I was allergic to fire ants, but it's the first thing to be affected is your brain. You don't think, oh, I have an EpiPen, oh, I have my Benadryl. By the time I realized what was happening, all I could do was I was just struggling to breathe.
So why did you have an altered level of consciousness?
Because of there was no oxygen getting to my brain.
And you're scared to death.
And I'm terrified.
But that lack of oxygen, and it didn't take long, did it? Guys, if this is your family member, at least get the Benadryl in. If they have an EpiPen and they fumbling with it, you snatch this from them and give them the epi. That epi is what solves the problem. And it hopefully buys you enough time to get to the hospital, because it ain't gonna go away. Once those meds wear off, it's gonna start again. Yes, ma'am.
Yeah, I'm allergic to fire ants too.
Some of the worst anaphylactic I have seen is from fire ants.
So I didn't know I was allergic to fire ants, so I had a severe allergic reaction. And my mom, instead of like giving me anything, she drove me straight to the hospital. She was like running like every red light, and she'd like stop in front of the hospital and like put the car in park without stopping. But when I got there, the nurse said that was the worst anaphylactic shock she's seen.
Honestly, you're lucky you didn't die. You must not have been too far from the hospital.
Like,
If that ever happens to any of your family and friends, if you can at least get them some Benadryl, it buys you a little bit of time.
yeah, I think she just didn't know what to do.
And girl, if you got the liquid, which one is faster, the little caplets or the liquid? Melt tabs are melt tabs are liquid. You put that melt tab on your tongue, it is instantaneous into the bloodstream because it's mucous membrane. Now, if you ain't got none of that, honestly, I'm gonna open that capsule and put it in your mouth, and you're gonna make a horrible face. I don't care. Airway, airway, airway. We still treat it the same. I am talking about, bam, hair trigger. Are we gonna? Yep. We sure are. There's nothing wrong with getting the airway box out. Okay, we didn't use it. No longer, no file. And you get it out, you ain't gonna use it. You don't get it out, everything is gonna go to crap. Guys, if the stinger's still in there, y'all get rid of it. If they bring the snake to the hospital, and it's not dead. This is where that southern terms in, well, bless your heart. But he had been told what? When you get bit by a snake, bring the snake in. So I was like, dead snake. Dead snake, not live, slithering. Got out in the emergency room, going out the door, snake.
The security guard, that poor guy. Just like,
get rid of the antigen. If you still had ants on you, please brush them off. And did you have the mentality at that point to realize? No. Because the more you get stung, what? The more of that antigen is floating around in there. Guys, I know we're not taking a break, and I know this is fast, but unfortunately we got cheated today. Oxygen. What kind of IV am I going to get if I can? Large bore. Meds, we talked about that. Benadryl, epi before anything. That's important for your test. And what's the other one? Steroids. It doesn't really matter if you don't give it in the first 2 hours, because steroids is the long game. Steroids is what maintains that anaphylaxis to help it from coming back. Neurogenic is very different with the signs and symptoms, and those are important for your test. But this is not hard. What are the global signs and symptoms of any other shock? Hypotension, diaphoresis, pale, cool, clammy skin, not flushed, hot, bradycardia. That's neurogenic. What causes it? Spinal cord injury, usually above T6. Guys, if you don't have a spinal injury, it's not what? It's not neurogenic. Now, you might not know beyond the shadow of, if somebody falls out of a deer stand or off a 30-foot building, they probably have what? A spinal cord injury. That might not be the worst of their problems, but they probably have that. What is a nervous system? It's your message. It's your computer. Well, if I walk in here and shut everybody's computer besides y'all throwing stuff at me, what happens? Your message system is shut down. I'm going to take everybody's cell phone after that, and I'm going to run. You can't get messages. And the brain's saying, hey, kick up the heart rate. I ain't doing it. It stops your sympathetic nervous system. And it says, we're going to eat cheesy poofs and sit on the couch. I don't care, I'm dying. So if the parasympathetic is in control, what's the heart rate do? It drops, and it drops bad. Cardiac output goes, blood pressure goes, and it results in what? Hypoperfusion. Massive vasodilation. It's still massive vasodilation. There just aren't any endotoxins. There's no antigens. Those are other specific problems. The problem gives you how to treat it. How are we going to treat this? We're going to handle them what? With care. Just because you have a little spinal injury, if you move them wrong, you can have complete transection of the cord. If it's above C4, they're going to die because that innervates their diaphragm. They can no longer breathe. And if you don't get them on the ventilator in like 5 minutes, don't be the reason your patient dies. We have to protect what? C-spine. These are the ones you're going to put a collar on. And until we get a collar, what? Somebody's going to hold their head still. Are you hurt? Yeah. Don't do that. Guys, it's always trauma. I mean, can anybody think of any other reason that your spinal cord would get broke? I mean, you might say, hanging, that's still trauma. They used to put them in the medical ICU, though. I did not understand that whatsoever. Of course, it causes hypotension. Neurogenic shock. This is key. Bradycardia, warm, dry extremities. You might have temperature differences. Might be warm up here, cold down here. Are any of the other shocks like that? No. Pale, cool, clammy skin, tachycardia, tachypnea. They might have hypotension, right? Did I say bradycardia? No, I didn't. Guys, if I gave y'all a question with bradycardia in it and it's the other shocks, I would be pointing you towards what? We at the end. I'm not going to do that. Because it's, guys, y'all have figured out by now, if I want you to choose this answer and it's hard for you to differentiate, you need to look for what? Key words. Severe, excruciating, catastrophic. Now, bradycardia might be in there, but what if I said severe, awful, terrible? I'm not going to say all three of those. Vital signs. What does that mean to you? I'm going to check pulses where? Everywhere. How do I check? How do I check motor? Guys, this is just a fast exam with a stroke, except not the facial and not the speech. Hey, grab my hands, squeeze down, squeeze like you're mad at me. And so this might be squeeze up here and that was not doing anything. Or I might get to her lower extremity. Hey, push up against my feet like you pushing up. I don't know. For sit-ups, nothing. Push down on the pedals, nothing. And then ask them, hey, can you lift your leg? Nothing. Guys, that something has affected the central nervous system. If they had a hellacious head injury, it'd be a traumatic brain injury, but they don't. Y'all, those are obvious. You feel along, oh, there it goes, down in their skull. Sensory is not hard either. Hey, can you feel me touching here? Hey, can you feel me touching in here? Can you feel me touching here? Where? That's positive. False motor sensory, everywhere. And it might be subtle. It's not always, I can't move my arm. Guys, spinal immobilization is key. Y'all remember in the primary survey, it was ABCs, but with a trauma patient, what went right along with airway? Spinal immobilization. This is a trauma patient. and I am suspecting they have a spinal injury, it is just as important. Because if you don't do this right, and you affect that cord even worse, now you got a problem with what? Your airway and breathing. And then you're going to have a problem with circulation. You're in a world of hurt. What kind of fluids? Crystalloids. What test is important here? At the minimum, what? Plain film. And if they really can't see anything, they're going to do what? CAT scan. Norepi is the treatment of, guys, you might see this one, and I bet everybody in here has used that medicine. You ever had a stuffy nose? And you've used what? Neosynephrine. What does it cause the vasculature in your nose to do? Constrict, and now you can breathe, right? It is a pure, nothing else, alpha-1 agonist. All it does is vasoconstriction. What's their only problem? They don't have an infection. They vasodilated to hell and back. Why not pick one? Evidently it's expensive. You won't see this very often. But if you do, for our purposes, I'm going to ask you about Norepi. But I just want, if y'all are working, who's at, y'all are at Vandy in the ICU, somebody is. You might see it at the bigger hospitals. And so I want you to realize, if they're on it, go in there and look at it. In the OR, they will give push dose pressors, and this is a big one. Why am I giving them atropine? They're bradycardic. Guys, that bradycardia and hypotension go hand in hand. Their sympathetic nervous system is gone. Like, it ain't working no more. Their communication system, there ain't nobody communicating in this house. So, here is the ugly truth about obstructive. Blood can't get in, or it can't get out. Pericardial tamponade can't get what? Out. And it can't get in. Because you put so much pressure on the heart, it can't get in the right atrium, and it can't get out what? The left ventricle and the great vessels. It is a mechanical obstruction to forward flow, to cardiac output. Cardiac output drops, perfusion drops. We go to anaerobic. Does everybody see how this ties in? You are going to go down that same continuum. Now, this is very specific treatment. We already talked about this. Cardiac tamponade, I've got fluid accumulating around the heart. I take a great big long 18, y'all are not, long 18 gauge needle, this is in the emergency room, and I point it towards your left shoulder blade, and I go in right by the xiphoid process and hope that I get in that itty bitty space to draw that fluid out. I never wanted to do that. I asked some of my coworkers, we did have protocols to do that, but usually it was during a trauma arrest, and this is, the chances of getting a trauma arrest back is 0.1%. Ain't gonna happen, so why not? We said the tension pneumo, originally we're gonna do a finger thoracostomy, we're gonna put that hole, we're gonna punch tube, this is where you normally put a chest tube. When we get time, we'll put the chest tube in, and then the PE. Now, what test? Still gonna be lactate, CMP, CBC, what's this? It's looking for clots. Guys, this ain't the end all be all. There's other things that make it elevate. It's just an extra added thing to tell us what? There might be a clot. Radiology, they'll probably do, they're gonna do plain films, and you will see this. They ain't gonna wait that long. What are breath sounds? They gone. If you got to the tension pneumo, there's nothing over here. If this is impacted side, if this is impacted side. If this is impacted side, which way does trachea go? That way. It don't go away where it's pushing. For the PE, they will do a CAT scan that's called angiogram, and it specifically looks for that clot. What is this specific to? Cardiac tamponade. That's it. What is this specific to? Tension pneumo. Guys, they're probably going to be tachypnic, but this is the global signs and symptoms. Their skin is probably going to be pale, cool, and clammy. It's not going to be hot flushed with hives. And they're going to be hypotensive. Vital signs, LOC. How many times have y'all seen this? I was working with a trauma nurse practitioner in a trauma ICU. We got to the door. This is my second day up there. Patient's better. What sort of voodoo magic did you just do? And I went up and I was like, how did you know that? She said, Charlotte, didn't you see their Foley was full of urine? She said, that Foley is the best indicator of your cardiac output and perfusion status of, I don't care if you float a swan. That's what I want to see. So if you're, damn it. Oh, I didn't break it. Why don't you break my house? How much are we supposed to make? Yeah. So if you make 20 and you were making 10 before, we're going what? In the right direction. If you make 20 and then you make 10, you better do something.